Hi, I'm Ann Eglash, a family physician and a board-certified breastfeeding medicine specialist in Madison, Wisconsin. I'm a clinical professor at the University of Wisconsin School of Medicine and Public Health, and I'm also the CEO of IABLE, the Institute for the Advancement of Breastfeeding and Lactation Education.
Hi, I'm Dr. Lena Edelstein. I am certified by the North American Board of Breastfeeding and Lactation Medicine, a board-certified pediatrician, and international board-certified lactation consultant. I care for breastfeeding diets in private practice in the outpatient setting.
Hi, Lena, how are you?
Doing well, Anne. How are you doing today?
Good, good. So it's time for a couple more topics on breastfeeding, and I'm going to hand it over to you to get started with something interesting.
All right, thanks. So today I'm going to be talking about the effect of ropivacaine-dexamethasone combination on postpartum uterine pain, inflammation, and breastfeeding in multiparous women. The authors of this article are Haiyun Yi, Xiaofei Wan, Dan Zhao, and Haiyan Huang. And this was published in the American Journal of Translational Research. So, this was a retrospective cohort study done to investigate the effects of epidural ropivacaine combined with dexamethasone on postpartum uterine cramping pain, inflammatory markers, and breastfeeding behavior, with the goal to add to the evidence based support for the management of postpartum uterine cramping pain and the achievement of successful breastfeeding. And I thought this was kind of interesting because in one of the deep dive modules, we looked at a different paper, Huda, from a Huda article from 2023, looking at how different forms of pain management after cesarean delivery impacted mobility and breastfeeding. So, a different patient population, but in a similar vein, in the sense that does managing pain impact breastfeeding outcomes? So, the authors referenced that postpartum pain reduces maternal comfort and quality of life and may also trigger anxiety and depression, thereby affecting early bonding, early mother infant interactions, and the establishment of attachment. They also note that pain induced stress responses inhibit the function of the hypothalamic pituitary axis. So, for example, it might be harder to achieve a milk ejection reflex. So, other studies have shown that women who start breastfeeding within 1 hour of delivery are twice as likely to achieve exclusive breastfeeding at 6 weeks postpartum compared to those who initiate later. So, the authors wanted to see if different methods of postpartum pain management, one, affects pain scores, and two, affects breastfeeding measures. And as a side note, they also measured markers of inflammation to see how that correlated with their reported pain. And I thought that was a super cool addition to the study to look at these biomarkers. So, traditional epidurals include a local anesthetic, drug like bupivacaine, ropivacaine, or lidocaine, and often include an opioid such as fentanyl or morphine mixed in with the anesthetic to provide stronger pain relief while allowing the laboring parents to remain awake and alert. So, the epidurals referred to in this article are not this. I learned something new, which may not be new to everyone, but it was new to me, this concept of a walking epidural. It's not something I've seen, but I thought important to consider because obstetric practices differ around the world. And my OB friend said that although she never worked in a facility that offered these, she has heard of other facilities that do. So these walking epidurals, the catheter is placed in the epidural space like a traditional labor epidural, but the local anesthetics infused still allow for some degree of ambulation. So, this study looked to compare the effects of an epidural with just the local anesthetic, just the ropivacaine, with an epidural that was a combination of ropivacaine and dexamethasone. So, I'm going to refer to these two groups as combo group and just anesthetic group, just for clarity moving forward. So, the dexamethasone, it's a long-acting glucocorticoid with potent anti-inflammatory and immunomodulatory effects. So, in this retrospective cohort study of 336 participants collected over 2.5 years from May 2022 to November 2024, three different hospitals in China included women who were aged 18 to 45 years of age, were delivering a fetus at 37 weeks or greater with a singleton cephalic presentation. They were having a vaginal delivery, and the patients were classified as low risk patients with little to no systemic disease. and they had to receive a postpartum epidural analgesia, and they had to have complete medical records. So the combo group had 172 patients in it, and the single group, the ropivacaine only group, had 164 participants in it. So the setup was like a general PCA. So the epidural is in place, a slow infusion rate was set, and then the patient had the ability to bolus themselves an additional dose of either ropivacaine-dexamethasone combined or just ropivacaine as needed. It was initiated immediately after delivery of the placenta and was continued for 48 hours until the catheter was removed. The severity of uterine cramping pain was assessed using the visual analog scale at multiple time points over the first 48 hours postpartum. When the pain score was above a certain threshold and a single PCA dose did not provide adequate relief, rescue tramadol was given. So during this 48-hour postpartum period, patients were encouraged to ambulate and breastfeed as early as possible. The inflammatory markers measured included tumor necrosis factor alpha, TNF alpha, interleukin 6, CRP, and interleukin 10. And the reasons why they measured these particular markers were that elevated levels of pro inflammatory cytokines may contribute to pain sensitization. And interleukin 10 is a potentially protective anti inflammatory cytokine. Other studies have found that increased interleukin 10 levels and decreased interleukin 6, TNF alpha, and CRP levels postpartum may help relieve pain and improve maternal physical recovery and well being. Now, the breastfeeding indicators that were measured included time to first breastfeeding, breastfeeding frequency within 48 hours, so how many times the babies were breastfed, exclusive breastfeeding rate at day 7, lactogenous onset time, which I think refers to the time to secretory activation based on the times that were reported, and breastfeeding self-efficacy scores. The primary outcomes measured were exclusive breastfeeding status on day 7 postpartum and pain scores at 24 hours postpartum. Most of this information came from medical records. The breastfeeding on day 7, that information was gathered by phone calls, and everything else that was measured was considered to be a secondary outcome. So the groups were overall comparable in terms of both maternal factors and neonatal related indicators. And the results of this study, so pain scores in the combo group were significantly lower than those of the single agent group at all postpartum time points, and with a lower rescue analgesia rates used in the combo group. At 24 hours postpartum, the observation group showed significantly lower levels of the inflammatory markers and significantly higher levels of the protective anti-inflammatory cytokine interleukin 10. The combo group had a significantly shorter time to first breastfeeding, a significantly higher frequency of breastfeeding within the first 48 hours postpartum, a significantly shorter time to lactation initiation, again, which I think they meant as secretory activation, a significantly higher breastfeeding self-efficacy score, and on day 7 postpartum, the combo group had a significantly higher rate of exclusive breastfeeding, almost 85% versus under 70%. So the authors then did a subgroup breakdown to see if among the different groups in their patient population, was there consistency across the different populations? And the discussion gets a little bit more interesting. So subgroup analyses were conducted based on parity and BMI, and the most significant differences were found when they looked at the subgroups based on parity. So of the 336 participants, 211 were multiparous. In the parity subgroups, pain scores at 24 hours postpartum were significantly lower in the combo group, regardless of parity status. In the multiparous subgroup, the combo epidural group showed significantly better rates of emergency analgesia, meaning that they used less emergency analgesia, and exclusive breastfeeding. While in the primiparous subgroup, there were no significant differences in emergency analgesia rates and exclusive breastfeeding rates between the two groups. So the primiparous subgroup did not have the same effects noted as compared to the multiparous subgroup.
So the emergency is the use of tramadol. So they used more
Right.
tramadol in the primiparous group. Like the first
Or
time moms with the first time baby used more tramadol.
I guess another way I would say it, not that the first time moms necessarily use more tramadol, but that the amount of tramadol usage was similar in whether or not dexamethasone was
Oh,
included
got it. Okay.
with the ropivacaine.
Okay.
So other statistical studies were done. So we know that the intervention was statistically significant in multiparous women. And although it didn't reach statistical significance in other subgroups, the odds ratio values suggested that the intervention tended to benefit the combo group across all of the subgroups. And just going to highlight this again, the intervention of including dexamethasone in with a ropivacaine epidural did not increase the rate of adverse events for either mom or baby. So, this study found that particularly in multiparous women, epidural analgesia using ropivacaine combined with dexamethasone was associated with lower pain scores at all postpartum time points, fewer needs for rescue analgesia, improved inflammatory marker profiles, and better early breastfeeding outcomes. The combo group achieved a shorter time to the first breastfeeding, higher feeding frequency within the 48 hours postpartum, and earlier initiation of lactation, and a higher rate of exclusive breastfeeding on day 7 without an increase in maternal and infant adverse events. So I liked reading the study because it expands the way I thought about post delivery pain management. Now, it would have been nice if they had included in the study as well a group where the walking epidural was not done at all, like have a true control, no intervention group to look at the effects of just even introducing the ropivacaine.
Right.
Um, and the study had several limitations that the authors did point out. For example, this is a retrospective cohort design. So why did some patients get the dexamethasone in the first place and others not? Like, was it a hospital policy change, a new anesthesiologist on staff? There's this potential for unmeasured confounding factors that just weren't like talked about in the article that I'm curious about. And the authors do also note that the study excluded patients with poorly controlled gestational diabetes. They had patients with gestational diabetes included, but those were well controlled. And they do highlight that dexamethasone should be used with greater caution in patients who do have abnormal glucose metabolism. There is some limited generalizability because obstetric practices do vary across regions and in different areas. But it would be interesting to see how this data would translate to beyond the first 7 days postpartum. Like, was this early improvements that they were seeing, will it continue beyond the first week postpartum and really have a big difference on long-term breastfeeding outcomes?
Yeah. I don't know that people, from this study, I don't know that people would be excited to put steroids into an epidural just based on this. Also, I think we just need to know, is using, an epidural catheter for a couple days after delivery with ropivacaine, is that in itself a reasonable thing to do? And I don't know if they put in the background if there are studies that have already done that. But just the weird design of this, like it's retrospective, but then they have these, they do these labs, and then why are they doing these labs? Like, did they do the labs? They compared lab results in those who didn't get the steroid and those who did? So then why are they, if it's retrospective, why do they do these inflammatory labs in people who didn't get epidural steroids? So I don't know. I really scratch my head at this, Sometimes I wonder about, is there
Like, it feels like the
honesty or
setup was there where it could have been a randomized controlled trial. Like, if they were already doing all of this, there couldn't that the potential was there to do that, but it was done retrospectively. So I wonder if there was another maybe they had a different study setup going on, and this became an offshoot of data that they were collecting for a different purpose.
Right. And that all should be disclosed in the study. Yeah. Yeah. So then it makes me, kind of always wonder. So anyway, I think the idea, the bottom line is that pain control is good. Pain control is going to help breastfeeding. We know that from the HUDA study. It's one other way that, these researchers looked at this topic. And I think we should, we talk a lot about how when parents deliver, or mothers deliver, it's like the candy wrapper candy thing where you've got the baby's a candy wrapper gets thrown away, not get paid attention to, yet we're still saying breastfeed your baby, but then we need to nurture the candy wrapper, right? And that part of that nurturing is providing that postpartum pain support, dealing with birth trauma. Yeah. So
Yes, and I like that they use the term uterine cramping specifically, like not just general pain, but specifically uterine cramping related to breastfeeding and that contraction of the
yeah.
uterus. I don't think I appreciated how significantly much like labor that would feel like, or the extent that the uterine cramping continues for. So I
Yeah.
like that terminology that they used.
Yeah. Yeah. All right. Well, let's
What
turn.
article do you have?
Yeah, I have one that talks about prolactin. And so this article is entitled Prolactin and High Metabolic Risk Pregnancies, Associations with Maternal Obesity and Metabolic Health. So it sounds like a lot, but really what we're trying to do is trying to understand, does prolactin mediate this relationship between having sort of a high risk metabolic profile and having low milk production? Like, do these people not make as much prolactin or respond as much to prolactin or something like that? So the first author is Kate Rassie, Rassie. She's from Australia. She's amazing. She's someone to watch as a lactation physiologist. And this is with her research group, which is called the TOBOGM group, TOBOGM. And it's a large study that's out of Monash University in Melbourne. It's called the Treatment of Booking Gestational Diabetes Mellitus Study. So this was published in Acta Obstet Gynecologica Scandinavia. I don't know if I got those terms right. That was in May of 2026. And so, again, this study is about investigating the role of prolactin in the association of higher BMI and insufficient lactation. So they wanted to start with, like, what do those prolactin levels look like during pregnancy in association with metabolic health? So just sort of for background, prolactin, we know, is the hormone that's produced in the anterior pituitary gland, and it plays a major role in the rate of milk production. And there have been studies showing that prolactin levels are lower among individuals who have adverse metabolic profiles, such as insulin resistance, metabolic syndrome, and elevated BMI. And there was, I think it was Kate Rasmussen years ago that showed, I think it was somewhere between 2000 and 2010, who showed that, gosh, when women who have an elevated BMI breastfeed early postpartum, their prolactin levels aren't as high. And that was sort of this one-off, maybe that's conflicted, that's weird. But then there's more data on this. So getting back to the background, during pregnancy, there's this gradual rise in estrogen over time, right, throughout the pregnancy. And that gradual rise in estrogen also drives the gradual increase in prolactin. And it's unclear if BMI and metabolic health influence this rise in prolactin during pregnancy. So there was a recent there were a number of research studies published from Scandinavia that showed that there were lower prolactin levels in both early and late pregnancy associated with higher hemoglobin A1Cs, which is that long-term marker for insulin resistance. And it was suggested that a low circulating prolactin during pregnancy could be a potential even marker of metabolic risk during pregnancy, so that they could just do a prolactin and say, you have some metabolic risk. This research, though, was largely done among white European populations, so it's hard to know how generalizable the findings are for other racial and ethnic groups. So this study wanted to look at pregnancy prolactin levels in relation to certain maternal metabolic parameters, within a more ethnically diverse cohort among women who have metabolic risk factors. So this was like a cohort within that larger study that I was referring to. And that larger study, the acronym is, again, TOBOGM for people who want to look it up. That larger study is an international multi-center randomized controlled trial of 546 participants that investigated the benefit of immediate treatment of early gestational diabetes before 20 weeks versus standard treatment at 24 to 28 weeks. And I don't have the results on that. I'm not going to talk about it, but it's a big study. So all these subjects were recruited between 4 weeks of pregnancy and 19 weeks of pregnancy and had at least one risk factor for hyperglycemia. So such as having previous gestational diabetes, having a BMI over 30, being over 40, a strong family history of diabetes, and having polycystic ovarian syndrome. So what I'm going to talk about, the number of people I'm going to talk about is 130 of these 536 study participants. And they wanted everyone who had polycystic ovarian syndrome to be in this. So they grabbed everyone with PCOS, and then they had another group that joined who did not have PCOS, but they all had these risk factors for hyperglycemia. So on average, these participants were around 33 years of age, and their average pre-pregnancy BMI was about 27 plus or minus 8. And they were like more ethnically diverse. So 44% were South Asian, 23% were white European, and about 11% were Southeast Asian, and about half were nulliparous. So everyone was evaluated for their BMI, their insulin resistance. Only half of them, I'm not sure exactly why, underwent a bunch of lab tests, including like metabolic lab tests. So they included prolactin, DHEA, testosterone, androstenedione, insulin, leptin, and C peptide. What's interesting is that when they divided the women into BMI categories, with BMI either under 30 or over 30, those who were over 30, they had higher systolic and diastolic blood pressures. And they also had a higher fasting glucose, higher fasting insulin level, and a higher C-peptide. So that all kind of makes sense. They also found a significant inverse relationship between pregnancy prolactin and maternal BMI. So the higher the BMI, the lower the pregnancy prolactin. Not only, so they measured the prolactin at 3 different times during pregnancy. So it was lower early, during mid-pregnancy, and late pregnancy. And so then, because elevated BMI was also associated with like higher blood pressure, they found that the pregnancy prolactin level was also inversely associated with the diastolic blood pressure and fasting insulin. So the lower the prolactin, the higher the diastolic blood pressure and the higher the fasting insulin. And what's interesting, they didn't see when they compared the groups in terms of like PCOS or not, they didn't see a difference in prolactin. And I've heard this before. In fact, I'm a co-author on one paper that didn't necessarily see less like adverse breastfeeding outcomes just based on PCOS. It's got to be these other factors because not everyone with PCOS has an elevated BMI, right? So one question about this data is whether having a lower prolactin level across pregnancy would be responsible for less breast growth and lower milk production postpartum. So I already mentioned that prolactin is really central in like playing a role in setting that rate of milk production, but it also plays a key role in the development of glandular tissue during pregnancy. So prolactin and progesterone play a really important role in developing that terminal bud, so really developing those alveoli. And then the authors discuss that there is research showing that gradual rise in prolactin during pregnancy does correlate with people reporting that their breasts grew. So, if people report less breast growth, I mean, that's always a hard one to know what to do when people say that, because obviously you and I see people like, my breast didn't grow during pregnancy and they make a ton of milk. So it's a perception thing, and it's always hard to to know what to do with that information. But there was a study that did show that there was less rise in prolactin. So it
So
would have
can I
been,
ask you about those 3 time points? So
yeah.
it was lower across the board, but was it lower but staying around the same level? So it was
You mean
more
the delta change from low to from early
like
to
from
late
first
pregnancy?
trimester to this later time point. Like was there also like a smaller delta, smaller change with time in that group?
Yeah, I'm not sure. I'm not sure about that. But at all time points, the prolactins were lower. They may have studied that. I don't know about the delta. So the delta, for those who are listening, means, the change, like if prolactin normally goes up by 100% from early to mid to late, did it go up 100% or did it go up less? I'm not sure. I don't have that answer, but it might be there. And we'll have a link to this article in our podcast, so you can always take a peek. So, all in all, I feel like this study is really kind of helping us put together some of these clues to understand that relationship between BMI, metabolic health, and lactation. In fact, one of the things that was really interesting about the study is that they didn't correlate the prolactin levels with actual blood sugar. And so I always think of this relationship with metabolic health as being related to insulin resistance and blood sugar. That's kind of what we talk a lot about, and whether insulin plays an important role, but it seems to be more so BMI than actual gestational diabetes. And that's what there was some research that came out of Australia recently that I heard from Donna Getty's lab, that I think where they identified that it seems more BMI than it does insulin resistance. So yeah, so that's kind of interesting too. And then the question is, if the prolactin level is lower at the end of pregnancy because of higher BMI, is that playing a role in the delay in secretory activation that we see in people with elevated BMI? And that, I don't know, it makes sense, kind of. Well, and I think in particular, if we go back to the previous research, that people with elevated BMI don't seem to respond as much to nipple stimulation to raise that prolactin. Is that contributing to the delay? So I think, it's a little clue, it's something to follow. And then, for those of us who are boots on the ground, we're like, oh, maybe we need to be considering domperidone or metoclopramide and
That's what I was going to ask
measuring.
you. I was like, ooh, so does this also change about what we think about when we think about having sufficient prolactin levels to maintain lactation? Like we kind of use this arbitrary cutoff of 100 or so, but maybe for this particular population, we look for their prolactin levels to give them an extra boost. Like maybe they would really respond well to having an extra trigger to secrete more prolactin.
Yeah, that would be, yeah. I think so. The idea that, we use like 100 as a cutoff is really more just sort of based on a few of us saying, hey, we don't really see milk production going up if the prolactin is over 100. But that doesn't mean, that 100 is normal or 125 is normal. We just don't really have that data. Even though there are charts out there, they're not necessarily to be believed because that research is just not robust enough. But yeah, you're right. Like, and also, is prolactin able to do its job? Is there some prolactin resistance too? So yeah, just a lot of interesting things to be thinking about. Definitely Dr. Rassie is someone to be following over time. There's a number of people actually who have really gotten involved in maternal lactation physiology research. Obviously, a number of people in Australia. There are some other people in the United States who are looking at this too, who I met at the Human Milk Institute conference in San Diego this year. So yeah, lots of exciting stuff. We can finally see some real movement that is beneficial for maternal child health on the maternal side. So
Yes.
yeah,
Also, now I'm curious about the gestational hypertension too. That's a whole other cohort where
that is.
that
Yes.
can be studied and see what their unique management could be to help optimize breastfeeding, breast growth, and breastfeeding.
Right. And for people who are listening, what we know is that there's this epidemiologic correlation between gestational hypertension and lower milk production, but we don't know the mechanism. And that's why we have to have these really brilliant researchers help us figure that out.
Thank you,
So,
researchers. We love what you do. You make our jobs better.
yes. Yeah. So we can explain it to the patients too. So,
Yes.
well, great. Thanks, Lena, for that time. And we'll talk to you soon.
Bye, Anne.
Bye. Thanks for listening. If you have questions or comments regarding this podcast, please contact us at admin@lacted.org. That's LACTED.org. You can also post comments or questions on our Breastfeeding Medicine Facebook page, and we will have links to our articles on the page. We have boatloads of breastfeeding education opportunities at our website, lacted.org. So come check us out and become a member to join our community.